Palpation, the findings of the inspection are confirmed. The chest movements are reduced on the right lower chest.
How did you palpate for the chest movements?
With the patient sitting on a stool, I gripped the chest with both hands with thumbs meeting in the midline and compared the extent of the outward movement of the thumbs during inspiration. I palpated in this manner in the upper, middle and lower zones anteriorly and then over the back. I found that the movements are reduced in the right lower zone.
How did you palpate for the apical movements?
By standing behind the patient, I kept both hands over the clavicles with the thumbs meeting in the midline posteriorly. I observed for the separation of the thumbs during inspiration and also the upward movement of the hands over the clavicles.
How will you detect diaphragm paralysis on palpation?
With the patient lying in supine position, I kept one hand over the sternum and one over the epigastrium. During inspiration, both the hands rise, indicating that the diaphragm is not paralyzed. If the diaphragm was paralyzed, the hand on the epigastrium would show paradoxical retraction during inspiration.
Proceed.
The trachea is central. The apex beat is in the fifth intercostal space, 2 centimeters lateral to the mid-clavicular line. That is, it is displaced to the left. Tactile vocal fremitus is absent over the right lower intercostal spaces below the fourth intercostal space in mid-axillary line.
What is tactile vocal fremitus?
Tactile vocal fremitus is the perception of vibrations produced in the larynx during phonation by a hand kept over the chest wall.
Why is it absent here over the right lower chest?
Because the vibrations are not conducted to the chest wall. The cause may be a pleural effusion, empyema, pneumothorax, fibrosis or collapse.
How did you test it?
I asked the patient to say 111 repeatedly with constant intensity of voice. Then I palpated with the ulnar border of my right hand and compared over symmetrical areas on both sides of the chest from apex to base in each intercostal space, first anteriorly, then along the axilla and then posteriorly.
Why did you palpate with the ulnar border of the hand?
To bring a closer contact of the hand bones with the chest wall.
Why did you ask the patient to say 111?
Resonant vowels like M, M produce the most satisfactory fremitus. So any short phrase in the patient's language containing these vowels will do. For example, 1, 2, 3, proceed. No other palpable vibrations, no intercostal tenderness over the right lower intercostal spaces.
Yes, that is a very important observation.
Yes sir, it rules out empyema. Intercostal tenderness is seen in pleural inflammation. For example, dry pleurisy, empyema, sometimes with pneumonia. And on the right side, it may be seen with amoebic liver abscess. On percussion, the superficial cardiac dullness extends 2 centimeters lateral to the left mid-clavicular line in the fifth intercostal space. Percussing the lung, chronic isthmus is normal on both the sides. There is a stony dull note over the right inframammary, infraaxillary and infrascapular regions. The upper border of this dullness is in the third intercostal space in mid-clavicular line, fourth intercostal space in mid-axillary line and seventh intercostal space in the scapular line. No shifting dullness, liver dullness is continuous with it.
What does this suggest?
A stony dull note rising up in the axilla without a shifting dullness is characteristic of a pleural effusion.
Why is it stony dull?
Because the underlying fluid damps all vibrations of the chest wall and the collapsed lung.
When is it impaired?
In consolidation, infiltration, fibrosis and collapse, where the amount of air in the alveoli is reduced. Also, it is impaired when the pleura is thickened.
When do you get a hyperresonant percussion note?
In emphysema, pneumothorax, large cavity, lung cyst and eventration of diaphragm.
And how did you test for the shifting dullness?
With the patient sitting on the bed, I percussed in the right axillary area from above downwards till I reached the dullness. Then I made the patient lie on the left side and percussed at the same point after 10 seconds. The area remained dull. It did not become hyperresonant, so there is no shifting dullness.
In which conditions do you get shifting dullness?
In hydropneumothorax or pyopneumothorax.
Proceed.
There is a boxy note of scoic resonance one space above the dullness.
What is scoic resonance?
It is a hyper-resonant note with a boxy quality heard over the relaxed lung just above the level of a pleural effusion. Rob's area is normal. Grocko's triangle of dullness is on the left side.
What is Rob's area?
Rob's area is an area of tympanic note above the left costal margin, bounded by lung resonance above, liver dullness on the right, and splenic dullness on the left. If it is dull, it suggests a left pleural effusion.
And what is Grocko's triangle of dullness?
It is a triangular area of impaired note over the back of the chest on opposite, that is normal side in case of a pleural effusion. It extends between a horizontal line at the 10th thoracic spine and the top level of the effusion in midline. It occurs due to a shift of the posterior mediastinum and compression of the opposite lung at its well-shaped base.
Proceed.
On auscultation, the breath sounds are absent over the area of the right lung marked by dullness on percussion. The breath sounds over the rest of the lung are normal, vesicular, with no rales, bronchi or rub.
What are the characteristics of normal vesicular breath sounds?
They have a rustling character. Inspiration is longer and louder than the expiration, and there is no pause between inspiration and expiration.
What are the different types of breath sounds that you know of?
Vesicular, bronchovesicular and bronchial. The bronchial breath sounds may be tubular or high-pitched, cavernous or low-pitched, and amphoric, that is low-pitched with high-pitched echo-like overtones.
What are the characteristics of bronchial breath sounds?
They have a hollow character, no rustling, expiration is equal to or longer than inspiration, and there is a pause between inspiration and expiration.
When are the breath sounds absent?
In pleural effusion, empyema, pneumothorax, bronchial obstruction and collapse.
What is a pleural rub?
It is a harsh grating sound heard during inspiration as well as expiration due to rubbing of the inflamed layers of pleura against each other.
How does it differ from the rales?
Pleural rub is a very harsh creaking sound compared to rales, which are fine crackling sounds. Pleural rub is a superficial sound and it increases on pressing the stethoscope, whereas rales don't. After coughing, the rales may alter, but rub is constant. And lastly, the pleural rub is associated with local pain and tenderness.
Did you expect a pleural rub in this patient?
No sir, as he has pleural effusion with fluid separating the layers of the pleura, pleural rub will not be produced. In early stage of dry pleurisy, he might have had the pleural rub.
Proceed.
Vocal resonance is diminished in this area, and at the upper border, egophony is heard. Whispering pectoriloquy is not heard.
What is egophony?
It is a type of increased vocal resonance where a nasal quality is imparted to the sound, seen just above the level of a pleural effusion.
When is the vocal resonance diminished?
In pleural effusion, pneumothorax, thickened pleura and emphysema.
And when is it increased?
Over a consolidation and a superficial cavity. When it is increased, the spoken voice is heard loud and clear, as if the voice is produced near the ear, though the words are not distinguishable. This is termed as bronchophony.
How did you test for the vocal resonance?
With the patient in sitting position, I asked the patient to say 111 repeatedly with constant intensity of voice. I auscultated over symmetrical areas on both sides of the chest, from apex to the base, first anteriorly, then along the axilla and then posteriorly. On examination of the other systems, the heart sounds are normal, liver and spleen are not palpable, no free fluid in the abdomen.
Why did you look for free fluid in the abdomen?
A right pleural effusion with ascites may suggest Meeks syndrome associated with simple ovarian tumors. It may also be seen in transudative conditions like congestive cardiac failure, hypoproteinemia and chronic renal failure.